Hey, some of you may have had your pregnancy listed as a high-risk pregnancy, or maybe a friend or family member has. So in this video, we're going to discuss what makes a high-risk pregnancy. Stay tuned. This is Expecting Series, where you get your information for your pregnancy matters. With that being said, my name is Eric Schmidt. I'm a board-certified OBGYN, and let's talk about what makes a pregnancy high risk. Now, if somebody has seen their obstetrics provider and they may be told that they have a high-risk pregnancy, or they maybe see it on their paperwork or the charting, it kind of sometimes causes some concern, some anxiety, that, well, why is my pregnancy high risk? Now, when we say a pregnancy is high risk, we're generally saying we're wanting to watch that mom and that baby a little bit closer. And actually, some practitioners might label every pregnancy that's not completely 100% normal as a high-risk pregnancy. And so, as you might imagine, there are certain things that are less concerning and certain things that are more concerning, and we monitor those pregnancies accordingly. For example, one of the most talked about, at least on social media, pregnancy diagnosis that makes people concerned or creates anxiety around pregnancy is advanced maternal age. You may hear people say geriatric pregnancy. You'll never hear me say that. But advanced maternal age is when a mom is expecting to deliver her baby when she is 35 years or older. And it does cause some concern, because if you read online and you're like, oh, what are my risks if I'm 35 or older? They say increased risks of high blood pressure, diabetes, placenta problems. And so all this seems very scary, especially for someone that is generally otherwise healthy and now might encounter these things in their pregnancy. And so while this technically falls under the category of a high-risk pregnancy, it's actually very low, usually on my spectrum of high risk when I see a patient that is 35 years or older. With no other risk factors, this increases the risk of the pregnancy minimally. It's not that much different that if someone was 33 or 34 or 35, the risk is very similar. And so in the grand spectrum of high risk potential complications in a pregnancy, this is extremely low. It only bumps up ever so slightly as a person ages their risk for developing gestational diabetes, their risk for developing preeclampsia or high blood pressure during the pregnancy, or placenta problems later on. And so overall, this risk is low on the spectrum. I don't want anybody to be too worried if they're getting pregnant over the age of 35, because sometimes you don't even need to change your prenatal care based on age, 35 to 40. Some might change it beyond 40 years old, but minimally. And again, there is a spectrum of high-risk potential disorders in a pregnancy, going all the way from, we talked about advanced maternal age or age over 35, being on the very low-end risk side of high-risk pregnancy. And so there's like obesity, and there's thyroid disease or something like that, maybe even history of a C-section. Generally those things don't worry us too much. There can be other things, history of preeclampsia, history of gestational diabetes, maybe requiring insulin, things like that, history of a tough delivery. And so these things, might get our attention a little bit more. And then there's certain things which are definitely more high risk, that definitely, if you are talking to your provider and you say certain things, certain keywords, they might lift their eyebrow a little bit and think, okay, yeah, that is truly a high-risk pregnancy, whether that was placenta problem, placenta previa, things like that. And so history of a lot of C-sections, there are certain things which are definitely things that we're going to monitor you a lot closer than if someone just has a more minor high-risk diagnosis. And so there's a range. So the question is, how do we manage a pregnancy differently now that it has the diagnosis of a high-risk pregnancy? Well, in, again, those more minor diagnoses, we might not monitor it differently at all. We just might monitor we might look out for certain things, but we might not do anything additionally, like make a recommendation for induction or things like that. It kind of depends on what the diagnosis is. But for some, in a high-risk labeled pregnancy, we might want to keep a closer eye on baby, and we can do this in a number of different ways. And so the question is, how do we do that? This would be with certain things like ultrasound. So potentially, everyone usually gets their 20-week anatomy ultrasound, but sometimes we wanted to do further ultrasounds down the road. That could be like to measure baby's growth, to measure the fluid, to measure and do a thing we call a BPP later on. Gives us a general idea in summary of how well we expect baby's doing and if it's safe to kind of proceed through the later half of the pregnancy. So for example, if somebody has a smaller growing baby, or what we call IUGR, or growth restricted, we might choose to do something like a BPP. And if it's reassuring, we keep going along. There's also another way that you might have had done to monitor baby's well-being, and that's do an in-office procedure at one of your prenatal visits. Again, usually this is later on in the pregnancy, usually last month, maybe 2, depends on the diagnosis again. But you might get what's called an NST. This is straps that might go around your belly, and they're going to listen to baby's heartbeat for about 20 to 30 minutes. And we look for certain things on this NST. We like to see that baby's heart rate is variable. We like to see that it has jumps up, or what we call accelerations. We like those things on the NST. It gives us reassurance that baby's getting good nutrients and oxygenation through the umbilical cord and the placenta. And we say, again, no concerns for baby. And so for what we're looking at with these NSTs and the BPPs is, again, wanting to make sure that baby's doing well, wanting to make sure that certain high-risk diagnosis is not causing any concern for your baby. And so then we are making a delivery plan if we need to potentially intervene or induce, or hopefully natural labor around the due date or term happens on its own. So what I'm saying with all of this is know your own history, know your previous pregnancies history if you have one, know your surgical history, because you want to convey that to your provider so that they can come up with your own individual risk and best deem whether or not how close they need to monitor your pregnancy, whether or not you are deemed a high risk or low risk. I don't know that it matters too much. It's more or less, where someone is on that high risk spectrum, how concerned we have to be about the mom, about the baby. And so getting the label of a high risk pregnancy is actually not that unique, right? Because it's so few that actual pregnancies have no risk factors. But the type of high-risk pregnancy matters. All right, quick little video. Hope you guys enjoyed that. Hope it clears up any anxiety, any stress about the situation of getting a high-risk pregnancy diagnosis. We'll look forward to talking to you guys in the next episode.